Thank you. If there are no additional questions at this time, we can move forward to Robert Wayant from the University of Pittsburgh School of Dentistry for the next session.
Thank you very much. Excuse me, seasonal allergies. Greetings, everyone. I'm going to expand a little bit on some of the comments that we've heard already and some statistics, and then we'll move on to having a conversation with our discussants. So let me just start by saying we're here today to discuss how oral health can be more fully integrated into overall health conceptually, and how we can consider ways to operationally incorporate oral health care services for patients across delivery settings that are outside of the dental office. So let me start by emphasizing that oral health is multidimensional in nature. It includes physical, psychological, emotional, and social domains that are integral to overall health and well-being. And oral health is subjective and dynamic. Good oral health is essential to eating, speaking, smiling, and socializing without discomfort, pain, or embarrassment. However, in the US, as well as globally, oral diseases are among the most prevalent and chronic diseases, leading to serious health and economic burdens and greatly reducing quality of life for those affected. The most prevalent oral diseases being dental caries or decay, periodontal disease, tooth loss, and oral cancer. Although oral diseases are largely preventable, they persist with high prevalence. And as with the most non-communicable diseases, oral conditions are chronic and strongly socially patterned. We saw some examples of that from Dr. Mays. Not only are oral disease more common in low-income and socially marginalized populations, but all too often these diseases remain chronically untreated. So let me just give you a few statistics that come from the recently released NIH National Institute for Dental Research report called Oral Health in America, Advances and Challenges. Some of the things that this report found were about half of all American children do not receive regular dental care because of socioeconomic or geographic obstacles. About half of all adolescents experience decay, and there's been little improvement in that in the last 20 years. Nearly 1 in 5 adults experience moderate to high dental fear or anxiety, preventing them from seeking needed oral health care. Oral health during pregnancy has been linked to some serious adverse health outcomes for both the mother and the child. Receiving appropriate oral care can be especially difficult for older adults when they are disabled, homebound, cognitively impaired, or living in long-term care facilities. And they often require team-based care to really be effective. More people now have public and private dental insurance than 20 years ago, but accessibility is still an issue, and in part because the majority of dentists in the US do not accept Medicaid dental insurance. Overall productivity losses in the United States due to untreated oral disease were estimated to exceed $45 billion in 2015, with the United States ranking the highest among the 195 countries. In 2018, about 66 million Americans had no dental coverage, with a dentally uninsured rate 2.5 times higher than a medically uninsured rate. And in 2014, there were 2.5 million emergency department visits for non-traumatic dental conditions that represented a $1.6 billion in charges and averaged nearly $1,000 per visit. So why is this so? In the US and globally, dental care delivery remains largely a cottage industry. It's delivered in a highly disseminated and small dental office model that are only loosely affiliated or organized in any way to actually address population-level oral health needs. This in part can be attributed to the very origins of the profession in the mid-19th century, when dental schools were first being created and for various reasons found themselves situated apart from the medical training schools and treated as totally separate institutions. Dental care then, and in large part today, is viewed as primarily a reactive surgical care model that focuses on treating the acute consequences of what are actually chronic diseases. The highly mechanical approach necessarily emphasized during dental education to create competent dental clinicians has exacerbated the inattention of the other healthcare training professions, as dentistry was viewed as something that they couldn't master and therefore couldn't enter into their curriculum. So even today, oral health issues are given very little curricular time in most non-dental health professional schools. A recent study found that on average, medical schools in the US spend less than 2 hours in their 4-year curriculum on oral health related topics. Coupled with this perception that dentistry was a separate profession requiring high levels of mechanical skill training, the evolution of healthcare policy mirrored this belief by creating separate but wholly unequal financing models for dentistry compared to what was provided for many other healthcare professions. Medicaid and Medicare in the US are examples of the policy neglect for dentistry. Eligibility for coverage under Medicaid is far more restrictive than eligibility for medical coverage. And even more stark, Medicare has effectively no coverage for dental care. And Medicare is designed to help older adults, often who are financially constrained, living on fixed incomes, to access health care. And once you're retired, you generally don't have employer-based dental insurance. That leaves out-of-pocket payments as the only way to access dental care. So these policy realities exacerbate the chronic access to care issues found the most among lower income and other vulnerable populations, with over 30% of the US population failing to receive routine dental care. Research in the US consistently shows that access to dental care is highly cost dependent, with nearly 50% of care financed out of pocket. The result is that cost of dental care is the largest barrier to access and leads to the associated oral health disparities among vulnerable social groups. For many, this means that dental care is sought only when symptoms become severe, or, as is common in many low-income child populations, whose oral diseases remain chronically untreated. Given that these barriers are the result of policy decisions on how we provide for access to dental care, these disparities are better characterized as inequities in oral health, and as such are considered unjust and in need of policy remedies. So where should we go now? Well, we now realize, after 30 years of social and behavioral research, that like most chronic diseases, oral diseases are strongly influenced by social determinants of health, and they travel with them in socially disadvantaged populations. And by that, I mean that individuals suffering from chronic oral disease are much more likely to also suffer from another number of other chronic medical conditions, and vice versa. It's also true that oral disease and many medical conditions share common risk factors. And by integrating conceptually oral health into overall health, it opens the door for developing a shared approach and a shared sense of responsibility if we are to really provide patient-centered care that adequately addresses patients with multiple comorbid health conditions that include common oral diseases. To create this needed change, we'll need to work at all levels where neglect for oral health now exists, including policy reform and care financing, changes in healthcare education, improvements in the care delivery system that includes workforce changes, and as we will be discussing, improvements in interprofessional collaborations and expanding the roles of other health professions as a means to improve population oral health and reduce oral health inequities. And the good news is that in the last decade, we have seen some advances in broadening out attention to oral health concerns across the broader healthcare delivery system. Recent developments of effective preventive interventions, such as fluoride varnishes that can be delivered outside of dental offices, has led to an increase in attention to oral health concerns in primary care offices. This has been accompanied by changes in procedural billing codes that allow for reimbursement for oral health services by non-dentists. Given that most children are routinely seen during well-child visits up through age 5, provision of effective dental prevention services in such primary care settings offers some hope that we can reduce these oral disease inequities. So we're also seeing the expansion of a new workforce model, such as dental therapists who can provide routine dental care and preventive services in non-traditional care venues, such as public schools, nursing homes, rural communities that lack dental services. So we also see more attention at the national policy level regarding increases in public funding for dental services. The Affordable Care Act expanded Medicaid, and it mandated dental coverage for children and adolescents, which was great news. Unfortunately, it didn't for adults. And recently, although unsuccessful, the conversation became quite quite serious about giving dental benefits to Medicare, and we're hopeful in the future that may in fact occur. So with all that said, let's move on to our discussants. So to begin, I'll note again that in underserved communities, there are few, if any, dentists or other specialty providers, and many kids don't even have their own toothbrush. Particularly in underserved or traditionally marginalized communities, the person's overall health tends to be the same as their oral health. So let me start with Lisa Maloney. And Lisa, you're a registered dietitian and a dental hygienist and an educator who works in communities significantly affected by social determinants of health. What is your view of the role of nutrition on impacting oral health?
Well, I only have a short amount of time to talk about it, but it's a large view. All of my worlds are combined. Again, I work with dental students, dental hygiene students, dental professionals, dietetic interns, dietitians. And, I oftentimes you were, speaking during about the, most updated current Surgeon General's report. And I always go back to, I'm kind of tying in everything that I've heard thus far, is the tooth isn't just, it's not just about the tooth, it's about the whole mouth. And I always tell everybody the mouth is connected to the rest of the body. As far as a dietitian, I can't go in and make recommendations for a client without knowing, or a patient without knowing, or just populations in general. One, do they have mouth pain? Do they have tooth pain, an ability, and then resources within the community? That's a big thing. We're very fortunate, many of us, that we don't think about, the nearest grocery store. Many people live in food deserts. Accessibility. I was hearing that term earlier. It's not just about access to dental care. Access to healthy food choices is a big concern, and that's where social determinants of health tie into. Health literacy, oral health literacy. They're different but the same, and having an understanding about the varied needs and the importance, and just someone taking the time to explain to someone, how food choices can directly impact their oral health. I've often said the same stuff, the same foods that cause cavities are the same ones that put weight on our bodies. Those same, we call them calorie dense foods versus nutrient dense foods. Very rarely will you see nutrient dense foods on a 99-cent value menu, and those are the ones who have limited funding and income. Those are the choices that they're going to be making. And/or if they live in neighborhoods with small local grocers, and I call it, they're going to typically not be filled with fresh fruits and vegetables as choices.
Great. Thank you. Let's move on. Jane Ziegler is a nutrition educator. Do you have anything to add to what Lisa just described? Oh, on mute. There we go.
There. I apologize. I always forget to turn off my on my microphone. So
Right.
Hi everyone, and I thank you for this opportunity to share ideas. We know that dental caries and periodontal disease, they not only have local effects on the dentition, but they impact several systemic conditions. So as an educator, really a nutrition educator across multiple disciplines, and this includes dentistry, medicine, nursing, the rehab professions, pharmacy, with a real emphasis on interprofessional education, I really encourage all healthcare professionals and kind of teach them, except for dentistry, of course, how to perform oral examinations, really look in the mouth and refer to the oral health professionals for diagnosis and treatment if they see some abnormal findings. One area that we really stress, especially in the nutrition sciences program, is the role of nutrition-focused oral facial examinations. And we really highlight how oral disease impacts medical and nutritional status of patients from both this local and a systemic standpoint. As you mentioned, Oral organisms have been associated with really serious systemic conditions, including endocarditis, joint and bone infections, and they stimulate this series of inflammatory reactions that really influence the progression of a variety of systemic diseases, such as atherosclerosis, diabetes. You mentioned adverse pregnancy outcomes. And these are all chronic illnesses that really impact our underserved community. And we know that some of these conditions can improve by oral treatments. And there's this like a bidirectional relationship that can exist, where, for example, like the treatment of diabetes may improve periodontal disease status, and successful treatment of periodontitis can actually lower blood glucose levels in individuals with diabetes. So being able to impact not only periodontal disease, but also improve blood glucose, you need kind of both the improvement of blood glucose control and the treatment in order for the patient to have a successful outcome. Other areas that kind of impact some of our marginalized population is aspiration pneumonia. We see this can happen in hospitalized patients, the elderly, our special needs population. So in kind of one of my roles is really trying to increase awareness of how oral disease affects the outcomes of our patient care. And I think this really calls for increased partnerships between the oral healthcare professionals and all of us as healthcare providers. And we really need to be a team in this effort. And it's like a concept that requires increased professional education between medical school, dentistry, all the health professions. And I'm including social work in that as well. And, I think that our students that we see that are actively involved in interprofessional education, whether it's reviewing a case study together and coming up with a treatment plan, or actually seeing patients together, it's kind of fun to watch the aha moments between the students in the different health professions when they're learning together. So I think the more we can provide of interprofessional educations, the better outcomes we'll see in terms of patient care.
Thank you. Great. So let's get a perspective from nursing and medicine. Let me first ask Judith Haber, who's from the College of Nursing at New York University, what her thoughts are on this. And we'll follow that up with Hugh Silk at UMass Chan Medical School. Turn this, not on, you're on mute. Yep.
Okay, thanks, Bob. I've had the wonderful fortune as a psychiatric nurse practitioner to be involved in the integration of oral health with overall health for the past more than 15 years. I lead a national nursing oral health initiative called ONEP, Oral Health Nursing Education and Practice, a core partner of NIIOH and Thanks CAS, funded by CareQuest for the last 10 years. Our grant engages the largest component of the healthcare workforce, the nation's 4.2 million registered nurses, more than 350,000 NPs, and more than 13,000 midwives. And what ONEP aims to do is to promote systemic change in the nursing and interprofessional workforce by integrating oral health and overall health through faculty development, curriculum integration, and establishing oral health as a best practice in clinical settings so that it becomes a standard of care across care settings and for populations across the lifespan. The nursing profession, as you all know, is on the forefront of healthcare 24/7 in the entire continuum of settings. So we really bear witness to the impact of both acute and chronic and community-based health problems. and the impact of oral health on overall health and vice versa. So the nursing profession is clinically positioned, and whether it's in an education, clinical policy, or research setting, we are clinically positioned to see the impact of poor oral health on overall health. Diamante Driver is a perfect example of how his last days were spent in one of our critical care units, needlessly, of course, and a tragedy that I think has stoked the challenges for us all to do a better job of working together. But whether the impact of poor oral health or good oral health on patient populations with cancer, diabetes, pneumonia, Parkinson's, stroke, those needing transplants, among others, is a vital concern to the nursing profession. And one thing I'd like to mention is that really the focus of integrating oral health with overall health needs to begin with pregnancy or even during preconception, because every mother and every set of parents, they want to be a good mother, they want to be a good mom and dad. And so they are really the gateway to their children and families' health, their oral health and their overall health. So that oral health literacy, we came up with the transition of the HEENT exam to the HENOT approach so that you cannot forget about oral health when assessing patients, and including oral health in management plans and documentation, because we know if it's not documented, it didn't happen. And we want to make sure that oral health is on the healthcare scorecard in whichever setting it takes place. You're muted, Bob.
If anyone has questions, please put them into the Q&A section of the Zoom, which is down at the bottom there. Now let's move on to Hugh Silk. And Hugh, how do you see your role in oral health as a physician, primary care provider?
Yeah, thanks, Bob. And I'm sorry I had a lot of IT issues, but can you hear me now? Okay.
You're doing fine. Yeah, we can hear you.
Okay, great. So look, we know, and I'm sorry I came in late, so this may have already been said, but it's worth saying again. We know that over 100 million people a year do not get in to see a dentist, but do get in to see a medical provider. We also know that there are millions who don't get into either. So we need to figure out what the role is for the physician, the primary care, the specialist, but also what's the role of those out in the community. But I'll speak to the physician side. We created what's called the Center for Integration of Primary Care and Oral Health, which we call CIPCO. And that is really to engage primary care providers across the country, whether they are pediatricians or family doctors or obstetricians or midwives or nurse practitioners, physician assistants, the list goes on and on. Whoever is coming in contact with folks needs to engage them around oral health. Now, we can't just expect that to magically happen. So we did surveys of all of those different organizations, all of those different professions and specialties, trying to get a sense of how much of this is being taught, because we're told over and over again that's not being taught. And actually, some are doing better than others. Nurse practitioners and physician assistants are actually doing a lot better than gets quoted. But there are still huge gaps across many programs, across many states. So this led to us helping to create core competencies and entrustable professional activities, EPAs, for medical learners, so that we could say, this is what we need to aim for. And what we've done over the last couple of years is create what's called the 100 Million Mouths campaign. And that is to have an oral health education champion in all 50 states to engage all medical schools, DO schools, PA schools, residencies, to use those core competencies, to use those EPAs, and to engage one by one learners so that at least the next generation, as they go out into practice, they will be thinking of the mouth as part of the body. As Judy said, they just are learning the oral exam in their physical exam course. They're learning the oral anatomy in their anatomy course. They are thinking about this with a lens on around health inequities in general, about diversity, inclusion, through cases, through statistics, through patient stories. So I think if we can get to a point where, again, we put the mouth back into the body where it always should have been. I feel like we've done that with behavioral health. I feel like as weirded out as we get by the eyes or the feet, we still treat those things. I think we're getting better with the mouth. And then in the meantime, there are numerous organizations, the National Association of Chronic Disease Directors with the CDC, putting together materials for practicing providers. Smiles for Life, which probably has been mentioned, would be mentioned again, has free CME where people can learn this in real time. We need to get to national conferences every year for professionals. We need to find ways to work it into workflow. I don't want to go on too long, but in Massachusetts, something like fluoride varnish is becoming part of our Medicaid accountable care organization. You will be held accountable to be putting fluoride varnish on children's teeth. If you're not doing it, you're not meeting the standards. You won't be getting paid at the level of the standards. So that's the carrot, that's the stick. And then we are providing free training to all providers so that they know how to do it. So, I mean, again, we've got these tools. We just got to take it state by state, town by town, school by school. But I think that's the role, Bob, that we all need to play and that we can achieve.
Thank you. That's tremendous. I'm very impressed that the implementation strategy you've devised is pretty solid. And it's really, if you're going to move the needle, you have to have the plan for the implementation. And that's critical. Thanks. So I'd like to shift the conversation slightly to ask what the role of social services and mental health care system play in addressing oral health as it relates to mind, mouth, body, and spirit of individuals. Dr. Rosemary Hemmings, you are a social worker by training and are currently at the Oregon Health and Science University School of Dentistry. Can you reflect on your role of social work in oral health and in the education of health professionals?
Yes, certainly. Social work as a profession, I think is uniquely placed as it relates to the work, as it relates to how social determinants of health impacts individuals. Social work as a profession, we focus on mind, body, and spirit, right? Providing holistic health, recognizing that where someone lives, where they work, where they play, where they worship, impacts their overall health and well-being. And, at OHSU School of Dentistry, my role is twofold. I work with social work interns, master's level social work interns who actually work with the dental students and their patients. I also work in the area of curriculum development around social determinants of health, where I teach the dental students about social determinants of health, health equity, social justice. One of the aspects of, I think, oral health, which has come up earlier today, is in terms of resources, how to access dental care, what insurance covers or does not cover oral health. And part of that is teaching the dental students to think about what their role is, not just in addressing the needs of their individual patients, but what role do I play in terms of advocacy on a legislative level, right? In my course, the dental students are required to read Mary Otto's book, Teeth. They're required to do 3 Harvard implicit bias tests on race, gender, and transgender. They're also required to work in group where they think about their future practice, right? Actually develop a practice and build a practice that would include addressing person-centered care around social determinants of health, thinking about what other disciplines would you bring into that practice? Think about where you would locate this practice, right? When you think about transportation, right? How would you help your patients around mental health issues? Oftentimes, I think social work is perceived as the field of, when someone needs resources financially, right? That's where you go to social work and actually helping the students by working with the social work interns to identify the mental health needs of their patients, right? We have patients who come in who have experienced domestic violence, sexual assault, teaching the dental students, how do you interact with a patient who's experienced such trauma, right? The mere fact that you as a dental provider, you're entering the space that the patient is in from the back, from their head, where they can't see you, right? So how do you address that, right? How do you work with someone who's experienced a significant trauma? How do you work with patients? We get referrals from our dental students about patients who come in with their children because they don't have childcare, right? Or who say they can't make their appointments because they can't take off from work or they don't have transportation. We work with the dental students where I have the social work interns role play with the dental students. And how do you do a suicide risk assessment when your patient is talking about that they feel suicidal? What do you do with that, right? How do you utilize some of the substance use disorder screening tools? And our students begin to see that the mouth is a part of the body, right? And having to day in and day out work with these social work interns, they're constantly reminded, right, that there are significant other impacts out there that this patient is interacting with that's impacting their oral health, and it needs to be considered. And when you think about holistic care, holistic health, you're treating the entire person. And you don't necessarily have to have, dental students will say to me, well, that's not really my thing. You don't have to have the expertise, right, and the lived experience of others, but you should know how to access resources and identify which discipline will be able to help your patient.
Thank you. That's a very impressive curriculum and that you have, Dr. Hemmings. I was glad to hear you talk about having Mariotta's book on your reading list. We do as well. But as I sort of think about it, as you said it, there's no reason we should limit it to dental students. I think all health professionals would benefit from just sort of lifting the lid up and realizing what's going on in oral health care delivery. And that book does it better than anything else I've seen. Very good. Thank you. So Dan McNeil, same question. Dan is chair of community and dentistry at the University of Florida. As a psychologist, how does psychology see itself in relation to oral health?
Thanks, Bob. Psychology, along with other behavioral and social sciences, is inextricably and wonderfully intertwined in all aspects of oral health. It's really about behavior and the outcomes associated with behavior, and perceptions, beliefs, attitudes, and other cognitive factors are involved as well. And whose behaviors are we talking about? Certainly dental patients of all ages and caregivers of those patients, but also the public at large, whether they use professional dental services often or not. We're also talking about the behavior of dentists and hygienists and other healthcare professionals, public policymakers, government officials, professionals in industry in the corporate world, and dental educators. Psychology also has a contribution to oral health researchers generally because of research expertise that includes psychosocial issues. And so the behaviors and cognitions of all these individuals and also the communities and groups they come from, what they do and what they say are psychological in nature and impact oral health at both individual and community and group levels. So in the realm of interprofessional healthcare education, there's numerous applications for psychology, and I'm just going to mention a few. First is in the realm of communication and interactional skills training, including patients, but not just limited to them. How do we encourage trainees and all professionals to be aware of inequities and how to respectfully and effectively communicate with all patients, including those from marginalized racial, ethnic, linguistic, and socioeconomic groups? And how do we be inclusive in our behavior? How do we interact with staff in healthcare settings, in dentistry, including in four-handed dentistry? How do we hire and manage staff? How do we interact with the public health sphere, with nonprofit organizations and public health departments and industry officials? How do we interact and communicate effectively with other health professionals? One of the privileges I have now is to provide leadership on a grant project that is training oral health professionals to deal with very young children and their parents and caregivers. And so that is, I think, a wonderful opportunity, as we talked about babies earlier, to try to provide a skill set to oral health professionals to bring children in early. A second area is on interventional skills that are psychologically based to address negative health behaviors, training professionals to utilize patient-centered approaches like motivational interviewing. How do we help these trainees learn to communicate their compassion and care for their patients who are afraid or in pain or both? We know that about 15% of the population has dental fear and anxiety that is significant enough that leads to them delaying or avoiding care. And about 15% of the dental patients who report for care are in pain. And sometimes you have both of those together. It's a special skill set to work compassionately with patients who are in that state. And so we really need to think about this holistic care of patients, including their emotional needs. And then finally, I just want to mention another realm of interventional skills, and that's in promoting positive health behaviors to enhance or maintain health. How do we motivate patients in self-care, in toothbrushing and flossing? We've heard from our nutrition and dietitian colleagues here. How do we prevent tobacco use and vaping? How do we encourage patients to wear mouth guards and athletic activities? There are many other applications of psychology and oral health. I was certainly impressed with Dr. Hemming's note about trauma, and that's an area of shared focus in psychology and in social work and how to help our patients in those situations. But I'll save some of my other thoughts about other applications. Perhaps I'll have time in a little bit later today. Thanks.
Yeah, I think psychology has an important role to play when training healthcare professionals who, a lot of social determinants are mediated through personal behavior of the individual patient, but what I don't think is often fully understood is that those behaviors have foundational roots in things that create their beliefs, their attitudes, and their behavior that are socially determined, and the social determinants put the guardrails on the behavior. And we have to be careful not to do some victim blaming when we see somebody who is maybe living in a food desert, and we're calling into question their dietary choices. Well, maybe you don't understand fully how that all unfolds. Thank you. Okay, so I'm going to shift, and we're going to think a little less vertically and more horizontally. So we consider oral health as an opportunity for interprofessional collaborations. For this, I'd like to turn to Lemmy McNeely. You are the Chief Staff Officer at the American Speech Language Hearing Association and also a member of the Interprofessional Education Collaborative. Can you explain to us your views on how oral health opens opportunities for collaborations that include speech-language pathology?
Absolutely. So when we speak, if a person is talking, right, they're talking using their mouth. And when children and babies have not yet learned to speak, right, they make sounds and they do things with their mouths, and they put hands in their mouths and they put toys in their mouths. And so speech language pathologists do oral mech exams And it's important that we are able to be educated along with our colleagues in other professions so that we each know where our particular areas of expertise lie, where there may be some overlap, and that's not a problem to have overlap. But if some babies are coming to see the speech language pathologist who are not seeing a dentist or not seeing some other health professionals, it's important that SLPs know that they can make those referrals if they have looked in the mouth and they see something that's either an infection or it appears to be malformations within the mouth that need to be addressed by a different professional. Having the opportunities for students from different health professions to be engaged in courses together, learning from, with, and about each other, and being enrolled in clinical practica together or internship experiences gives them that education while they're students. It's also important that once those of us who've already started practicing and are not in an academic setting, unless they're in an academic health setting where they do have a clinic, need to also know what are the advantages and opportunities that exist to facilitate a child or the family's access to services that help them to have good oral health. We've been talking about the connection of the mind, mouth, and body, and we really should not be separating those. And I think sometimes different professionals get caught up with their scopes of practice and say, well, that's not my area, it's your area. And am I crossing over the someone else's territory, if you will? Well, speech language pathologists don't own the mouth. Dentists don't own the mouth, right? People, individuals own their own mouths. And we all have some requisite knowledge and skills about the mouth. And we should be able to share that information and know when there's something that is outside of a particular profession's scope, to be able to know, who do I take this to? Who do I make the referral to? And that's something that we can certainly make sure that we're including. The international, the IPEC competencies address an array of skills and behaviors that we should have knowledge about that include the oral cavity, the mouth, as well as the rest of the body. So these are really opportunities for us to see a patient and a family, and then understand if something's outside of my scope, who needs to know about this in addition to me, because it may impact something that's within their ability to eat safely, swallow safely, and it may also have a health need, right, that a physician or a nurse needs to have access to that person about. So I think some challenges that present themselves with practitioners is that they are not always in a position where their practice is set up and structured to communicate with another healthcare provider who's in a different profession. And those who are practicing in healthcare centers that have multiple disciplines have an easier approach to being able to make those kinds of connections. And I do believe it's around relationship building and understanding why dietitians, dentists, dental hygienists, SLPs, occupational therapists, nurses, and the list goes on, are important relative to oral health, in addition to them being important relative to a person's overall health. So I do think that we have some wonderful opportunities and some significant challenges in addressing the needs of individuals in different settings, whether they're in urban communities, rural communities, suburban communities, so that they have access to the services that they need. And if a person comes to an SLP and hasn't been to a dentist, and the child is 1 year old, that's something that should raise a red flag for me to say, I need to make a referral and talk with the family a bit more about the value and importance of oral health and the value and importance of seeing a dentist or a dental hygienist, or even to see a nurse or someone else who can help them with that, so that we're preventing pain. Because if we wait until people are experiencing pain, all they want to do is close their mouths and not let anyone get in there.
Thank you very much, I'm reminded how we have a very strong presence of speech language pathologists in our cleft palate center at Pittsburgh, and how important they are in helping these kids. Alrighty, so it's now time for our public health representative, Colleen Lampron, who is the owner of AFL Enterprises and has expertise in planning innovative initiatives that promote access to care for underserved populations. Colleen, public health is naturally interprofessional, which means like it lends itself to looking at oral health through the lens of a mind, mouth, body, and spirit. Can you share with us any examples of how you see public health playing a role in addressing oral health that improves the health and well-being of the entire community?
Yes, thank you so much, Dr. Wyand, and thank you to the panelists and the participants. It's really great to be here today. So the three core functions of public health are assessment, policy development, and assurance. And public health approaches really recognize the multifaceted nature of disease and then focus on addressing individual, environmental, and social factors that contribute to better outcomes. And so as we think about what could a new system look like, the role of public health, I think, is significant in the conversation. By looking at the system as a whole, it allows us to understand the current state and then develop policies and systems that deliver better outcomes and then monitor those systems to assure that they continue to achieve the desired results. And I brought a graphic. I don't know if we're going to be able to show it today, but there it is. Okay. I've been working on this with the National Network for Oral Health Access. And we've been envisioning what could a delivery system look like if we really were thinking about a comprehensive system where everyone gets the support they need to attain their full health potential. When you think about dental care, a dental operatory costs about $150,000 to build. Dentists are trained as surgeons primarily. And so this system envisions that the dental treatment center is clearly a significant part of delivering care. But if we change the way that we use the workforce, the way that people get access to oral health and I think as Lemmy said, right, like put the ownership of the mouth back into the hands of the individuals, and develop a system that looks at prevention. I think that we can really address better access. And so specific to your question about examples of how public health has been working together, so public health works with policymakers to get better policies that allow better access, that allow better payment, that allow the payment for services that we know are evidence-based. And then, education, mental health, and most importantly, families and communities to test a variety of models for care delivery, such as school-based sealant programs, the virtual dental home, which is sort of envisioned in this graphic, where you can send dental hygienists out into the community settings to deliver preventive services and all services within scope for the dental hygienist, and then using telehealth technology, link them back to dental delivery. And then teledentistry, which is something I see as having tremendous potential to break down access barriers and build relationships to teach and support self-management, create lasting change. And so public health is with all of you in this work, and we're excited to be part of the conversation.
Thank you very much, Colleen. So we're going to move on to sort of throwing question out for all of the discussants. We sort of heard their general approach for their profession. I sort of want to get a feeling of what these ideas, what kind of barriers are they going to run into when we try to expand sort of awareness and the practice of anything related to oral health into non-oral health related healthcare professions, and what potential facilitators exist out there to make that an easier transition. We can, just as you think of something, please just use the raise hand feature, which is down at the bottom, and we can call on you. But we're just sort of looking for identifying where the barriers and facilitators are to improve interprofessional collaboration around oral health.
Yeah. Hi. Oh, sorry.
Jump in.
I didn't raise my hand, so.
That's okay.
Yeah, I'm just thinking about my journey at OHS School of Dentistry as a social work, public health professional coming into a space of dentistry where there was no one else like me, right? In terms of profession. And I think one of the key issues that I found, and I think it's something that needs to be addressed is, and correct me if I'm wrong, but social determinants of health and the putting a mouth back in the body and holistic health is newer, I think, to the field of dentistry, right? And because of that, I think a lot of work needs to be done on those, who currently have been in the profession of dentistry for a very long period of time, who are currently in academia, especially who are responsible for training our future dentists, right? Practitioners. So I think a lot of work, just think about my experience, a lot of my work in terms of implementing, developing the social determinants of health curriculum, really centered around working with faculty, dental faculty, who this was totally new for them, right? In terms of having to think about, well, why should it matter whether or not this person has a mental health issue? I don't see it really impacting, and trying to explain what we mean when we say holistic health, when we talk about social determinants of health. So I think a lot of work needs to go into the field of dentistry in terms of, providers who have been in the field for a very long time and who this is a totally new way of thinking, a new approach in terms of providing patient care. So that's my thoughts.
Well, I would say, Rosemary, that the opposite is true as well, that trying to introduce oral health and have it valued in the nursing profession and other professions, pharmacy, medicine, it's a journey.
Yes.
And there are several barriers in practice aside from those on the education side, which the IPEC competencies have really been a help in moving the needle forward, because while people may not be interested in oral health, when you say that oral health is an excellent clinical exemplar for operationalizing the IPEC competencies, all of a sudden they sit up and take notice. But overcoming barriers to lack of knowledge and awareness is really having repeated exposure of students and faculty, and you have to include professional development, because as you said, those who are educated pre-oral health, who are not in the dental profession, and vice versa related to overall health in the dental profession, they need to catch up a lot. So faculty and preceptor development is key in overcoming the barriers to being receptive to integrating oral systemic health clinical experiences, whether classroom, live, or simulated. And we have developed many of them, as well as online resources through the ONEP program to make them happen, that are models.
Agreed.
Thank you, Judith. All of you have your hands up, which is great, but I didn't see who went up first, so I'm just going to go around the order that they appear on my screen. You're next up.
I just want to pick up on that theme. We definitely don't need to reinvent the wheel, and we have been doing this for a long time. We just need to use appropriate analogies. So when it comes to education, we're evolving our curriculums all the time. I mean, we're in the middle of one in our med school right now. So it's when people say, "Oh, we don't have space for that," it's like, what? We weren't doing social determinants of health like 5 years ago, and now we are. You made space for that. I think the key is to how do you weave it in so that it's not like all of a sudden a whole lot for any one person. And at UMass Medical School, one of the things we've done is we've made this sort of spiral curriculum where there's a little bit in anatomy and a little bit in the exam and a little bit in physiology, a little bit in cardiology. And so, you know, nobody has to do a whole lecture on it. It's embedded into a lecture, embedded into a case. Plus, then the mouth becomes part of the body because it's not this standalone, here's your one lecture and you're done. So I think that's part of weaving it into education. I think weaving it into workflow, I mean, we've done vaccines for a long time, but there was a time when that was new and we just, you know, figured out who's going to do the vaccine. You know, in my lifetime, we've added foot exams, we've added behavioral health screens, we've added all sorts of things to my office. And you look around and you say, okay, well, could the medical assistant, you know, do the monofilament testing of the foot, but should the clinician actually feel for the pulse? And should this person do this? And so, you know, you can have a screen for oral health risk that's done at the front desk. You can have a medical assistant apply fluoride varnish. You can have the provider do the oral exam. So again, just little pieces of it so that no one's overwhelmed by it. And then again, I think Judy's right on. You've got to make sure that people are trained appropriately in this. So making that as accessible as possible. I think Maine with their From the First Tooth program has made it like, you know, they used to go office to office. Now it's all virtual CME, CE training, and you can be up and running without anyone ever coming and training you. So again, we've been doing this, we have the tools, we just need to get people just a little bit excited about how important it is.
Great, thank you. Lisa.
So many great comments that I wanted to piggyback on. I'm just going to go on what Hugh was saying. As far as dentistry, I think I'm going to disagree just a little bit with Rosemary as far as it has been in dentistry. It's just, you know, applying it broadly. And I like what Hugh was saying as far as integrating it into the little small bites and making sure that it's a part of the overall, you know, program, the curriculum. I not only integrate it here at the school, but, you know, traveling when I speak to dentists and dental hygienists out in, you know, in the profession. And that's the one thing you'll see in the literature why, you know, perhaps they don't address diet as it relates to oral health is because they don't feel like it's their area. They don't feel that it's, you know, they're have been educated on it well enough to actually advance it. So I think the more that it's infiltrated, you know, in small bites, so it doesn't just fall on one person, absolutely, that it is an essential component of what we're doing. I have so much more I can say on this, but I see a lot more hands. I'm going to let some others add on.
Dan, you're next.
Thanks, Bob. In just thinking about oral health and in integration with other areas, earlier we talked about two pathways, you know, integrating other groups into oral health education, but also bringing oral health to other professions. And I'm reminded about 50 years ago, there was a rallying cry by a president of the American Psychological Association who said, we should give psychology away, meaning we should bring it to every other healthcare discipline and not be insular. Well, that's still a work in progress for psychology, certainly, but just think about motivational interviewing as one example. And I would suspect that everybody who is here today knows something about that, and it's probably integrated in at least most training programs. I think we can also give away these bites that we're talking about of oral health in what should be trained in psychology programs, what should be trained about oral health in physical therapy. And so it should be this bi-directional kind of operation, because I think that will expand it. It will allow us to give away that important knowledge about oral health.
Great, thank you. Jane, then Colleen.
Sure, thank you. You know, it was interesting. Yesterday, I gave an all-day seminar on nutrition-focused physical examination, and I had a current student in the classroom as well, who had been trained on nutrition-focused physical exam. And it was really interesting how she was helping professionals who were already dietitians in practice, who were very uncomfortable with looking in the mouth. And I kind of agree with Judy. Our current students have grasped the need for this interprofessional care, but some of the practicing clinicians are uncomfortable because they haven't been trained, and they're looking in the mouth and they're like, well, we're not dentists, we can't diagnose. And I'm like, well, we're not asking you to diagnose. We want you to look for abnormal findings, and that's when you refer. So I think, the practitioners need a push as well in terms of educating and how to look in the mouth.
Thanks, Colleen.
So to your question about the barriers, it sort of gets to one of the questions that's in the chat from Dr. Holtzman about what potential measures could capture social determinants of health into caring for the oral health of patients. And we actually are running a diabetes collaborative with some federally qualified health centers. And so we've got medical and dental working together, and we just met with them last week. And so we're teaching them the HRSA interprofessional oral health clinical competencies. And I think to Jane's point that, as soon as you say, hey, we want you to look in the mouth, they're like, oh, I don't want to look in the mouth. I don't want to see. But then with just a tiny bit of training, and really testing it, like the first time they do it, like, oh, this helped me have a better conversation with my patient. And so I think that the barriers really are, data is one of the big barriers, right? Like even in FQHCs that are in the same building, we can't tell you with accuracy if a medical patient also had a dental appointment. And so the work that is going involved into getting that kind of data. And so to get to Jennifer's question and to your question, Bob, about barriers, I think data is a big opportunity. But I think we could measure things like whether or not a primary care patient has dental access, and you could even look at it by subpopulations: pregnant women, patients with diabetes. And then I think the other one is self-management goal setting. Like, can we measure whether or not a patient set a self-management goal, and then is the team actually using that motivational interviewing technique?
Judith, you're more than welcome, and we have 5 minutes left, and if there's any time after your comments, we'll do questions from the audience. Go ahead, Judith.
One thing that hasn't been mentioned that is a barrier, but would be a facilitator if dissemination of an interoperable electronic health record. And that is one of the barriers to there being synapses between education and practice. As long as oral health is not a standard of care, a required quality measure, or required documentation field in medical electronic health records and general health in the dental record, and for interoperability, it's a barrier for this being disseminated widely across the professions. So there is great progress being made, especially with Epic and other vendors, through other EHR vendors, but that is something that really requires an investment, a national investment by healthcare to make that happen. And then it will become a facilitator to interprofessional collaboration.
Thank you. Mayumi, do you have any questions in the Q&A that we could address?
Yes, actually, I think this one was popped up earlier, and I wasn't sure if you saw it. Somebody in the audience asked, when thinking about reimbursement rate and cost, I'm curious about your thoughts about expanding the roles of dental hygienists or expanding the dental profession to include dental therapists. If someone is able to answer that.
Have thoughts? I think it's a good idea.
Patty Brown's work in Colorado is a great example. Cavity-free by 3 and getting dental hygienists into medical settings. And this has been done in Pennsylvania as well. And one of the things I know that they noted in Pennsylvania was The dental hygienist was in the office. The dental hygienist was doing a certain amount of work herself. And meanwhile, the medical providers started to up their game just with the presence of the dental hygienist being there. So they were applying more fluoride varnish. They were doing more oral exams. It's almost like through osmosis, their confidence level went up. And I think part of it was like, well, if I'm not sure exactly what I'm seeing, I can walk down the hall and get a quick consult. So people were doing more. And so that idea that I think Colleen had put up earlier, about having dental hygienists in medical settings, we have, I've been in offices where a dermatologist comes once a month, an orthopod comes once a month. We have a psychiatrist that's in our office every day. I have therapists that are in my office every day. Again, not a new concept to have someone there who can do bits and pieces of this depending on what your volume and need is.
Excellent point. Anyone else? My sense is that with alternative payment models and value-based care, that the emphasis on outcomes and patient-centeredness will facilitate more relaxing of these rigid rules around scope of practice and expand the collaborative model so that everybody gets to the same endpoint, and that benefits all the providers as well as all of the patients. So I'm hoping to see some movement based on maybe accountable care organizations and getting oral health on board. Dan, were you going to say something? Nope. Okay. Well, I think we're, are we at time? No, we have a few more minutes. Any other comments before?
We do have a couple of more questions in the Q&A. There's another question that's asking about whether or not you see resistance from the ADA on this issue, and if so, how might we go about fixing this?
My sense is from a few things I've read just recently last month that it's not resistance, it's actually embracing this idea and trying to sort of expand that notion of interprofessional practice. And so I don't see that. I don't know if anyone else has seen something different. Nope. Okay. And then there's this one last
Do we have
comment.
time for one more?
Yeah, let's give it a shot.
Okay. This person is asking that they would like the group to consider interprofessional education with dental hygienists, dental therapists being educated together with other healthcare professions, nurses, physicians, PAs, etc. Their roles for professionally educated allied dental manpower can work in alternative settings, such as hospitals, community centers, if allowed by state regulations, i.e. allowing these professions to be allowed to be supervised by physicians or other health professionals when and where appropriate. Note there are over 300 dental hygiene and dental therapists, and their graduates are capable of treating and preventing oral health disease.
Right.
Thoughts, comments on that?
Great point. Dan?
I just wanted to mention something that we're doing at the University of Florida that makes me very happy. From the first year in dental school education, they are involved with students from other professional groups in interacting with an actual family under supervision of faculty, of course. But from the very beginnings of their training, they're being exposed to other professions and learning about, different perspectives and viewpoints and needs. And so I think that early education is just very important.
Yeah, there's something about what you learn in your first professional degree that sort of frames the rest of your career, and changing behavior 5 years after you graduate seems to be the hardest thing.
I echo that, Dr.
Yeah.
McMillan, I echo that too.
Yeah. I teach evidence-based practice, and boy, it's like pulling teeth to get somebody to change after.
No pun intended.
All right, we're going to wrap up there, I think. Thank you all. Great panel, great discussion. Appreciate your time and efforts. Thank you. And I'll give it back to who's.
I'll take it.
Okay,
yes.
Isabel. Yeah.
Thank you so much, Bob, and the roundtable discussants. for great insights and for keeping it all on time. It seemed like it would be nearly impossible, but it was absolutely stellar. So we are going to have a break